Dysmenorrhea. Dysmenorrhea means the pain related to menstruation that may occur just before or during menses. Types of dysmenorrhea: primary spasmodic dysmenorrhea, secondary congestive dysmenorrhea, membranous dysmenorrhea, and ovarian dysmenorrhea, which may be ovarian pain or premenstrual tension syndrome. Spasmodic dysmenorrhea or primary dysmenorrhea, it is a severe colicky pain in the lower abdomen that may be radiated to the suprapubic region or to the inner aspect of the thigh and may accompany with backache, lower backache, and other symptoms such as nausea, vomiting, headache, diarrhea, and fatigue. Incidence: it is high, about 72% of women may have primary. Etiology: it is associated with uterine hypercontractibility characterized by excessive amplitude and frequency of contractions and a high resting tone in between the contractions. During contractions, endometrial blood flow is reduced due to the 8-figure shape of the myometrial muscles. In between the 8 figures, there is blood vessels or blood supply to the myometrium and the endometrium. So during the contraction, there is a spasm over the blood vessel supplying the endometrium. So there is a good correlation between minimal blood flow and the maximal colicky pain, and the prostaglandin and leukotrienes level elevated. Presentation and assessment: in general, primary dysmenorrhea appears 6 to 12 months after the menarche, when ovulatory cycles begin to become established. The early cycles after the menarche are usually anovulatory and tend to be painless. The pain usually consists of lower abdominal cramps and backache, and there may be association with gastrointestinal disturbances such as diarrhea and vomiting. Symptoms occur predominantly during the first 2 days of menstruation. Diagnosis of primary dysmenorrhea. The diagnosis of primary dysmenorrhea is one of exclusion. If symptoms are typical of primary dysmenorrhea, the therapeutic trial may be used before considering any examination or investigation, especially in adolescents. If clinical evaluation raises suspicion to secondary dysmenorrhea, transvaginal ultrasonography or even MRI or laboratory should be considered. If symptoms of primary dysmenorrhea are not related with either non-steroidal anti-inflammatory drugs or combined oral contraceptive pills, secondary causes of dysmenorrhea need to be considered. Management: first of all, reassurance and explanation. Non-steroidal anti-inflammatory drugs such as COX-1 inhibitors such as mefenamic acid, ibuprofen, and aspirin are all effective. Starting treatment before the onset of menstruation appears to have no advantage over starting treatment when bleeding starts. The combined oral contraceptive pills, they act by inhibiting the ovulation and decreasing endometrial production of prostaglandin and is used especially when fertility control is required. Secondary congestive dysmenorrhea, it means that continuous dull aching lower abdominal pain accompanied by headache occurring in multiple women after many years of relative painless menstruation due to the pelvic congestion, which is more marked in premenstrual period, and this is a sign of anovulatory cycles. Incidence: it is common in multiple women between 30 to 40 years. It starts few days to 3 to 5 days before menstruation, increased in severity as menstruation approach and relieved by the onset of menstrual flow due to diminution of pelvic congestion. Etiology: it is caused by pelvic congestion that caused by simple congestion as constipation or coitus interruptus, chronic inflammation as cervicitis and salpingitis or PID, neoplasm as fibroid, endometriosis, and IUD. Third type of dysmenorrhea is membranous dysmenorrhea. It is a rare condition resembling spasmodic dysmenorrhea, but in addition with endometrium shedding in the form of one big triangular membranous cast due to abnormality in the separation of the endometrium. Fourth type is the ovarian dysmenorrhea. It is the premenstrual blood aching pain occurring in one or both iliac foci in patients with pelvic congestion leading to ovarian congestion. Ovulatory pain, it is mid-cyclic pain in one iliac fossa due to increased tension in mature follicle or rupture of the follicle at the ovulation time, causing irritation in the peritoneum. It is also called Mittelschmerz pain. Premenstrual tension syndrome or premenstrual syndrome, it is a premenstrual irritability, depression, mastalgia, sensation of fullness in the abdomen which occur few days before menstruation and relieved by menstruation. It is due to salt and water retention or increased estrogen and deficient progesterone. Premenstrual syndrome incidence 3 to 9% of women. Definition: a woman considered to have premenstrual tension syndrome if she complains of recurrent psychological and or somatic symptoms occurring during the luteal phase of menstrual cycle and resolve in the follicular phase at least by the end of menstruation. Symptoms: typical psychological symptoms of depression, irritability, anxiety, tension, aggression, inability to cope, and feeling out of control. Classical physical symptoms like is bloatedness, mastalgia, and headache. Treatment of premenstrual syndrome: non-medical or medical or surgical therapies. Non-medical therapy such as exercise, yoga, acupuncture, and psychotherapy. Of course, the exercise is the most important. Medical therapy: the supplementation of calcium, vitamin E, magnesium, vitamin B6, and dietary change. Serotonin reuptake inhibitors such as fluoxetine 20 mg daily during the luteal phase only. Surgical treatment: oophorectomy followed by hormonal replacement, but it is considered too aggressive as a treatment for premenstrual tension syndrome. Cyclic suppression by oral contraceptive pills, Danazol, GnRH analogues for the treatment of premenstrual syndrome. And thank you.